Hello, hello. I feel like we both need new headshots.
Oh, I didn't even see which one it was. I think it's like I have a newer headshot, but I think they use like an old one. But you
Same.
always have you always have a good photographer. You need to tell me when you're gonna do your headshots, and I will fly out to Texas to get them
We'll
done.
do them together. No, that's totally fair. But the one that they use of mine is definitely very old as well. And I definitely have newer ones. And I'm like, oh, Chris and I look so young.
I think honestly, the picture that was just up was from like 2015. I got one from like 2 years ago that I have, but
Yeah.
I don't know if you're like that. Maybe it's because I have BDD. I just hate taking pictures. So I'm like,
I
when I find a good one, I'm like, we're sticking with that forever, even if
know.
I'm 10.
Well, and I feel like it's hard because like pictures that I'll be like, oh, I like this one. It's like on an iPhone or something. It's not good quality, so it can't be like blown up and used. So it's like headshots have to be a specific whatever they call it. You know what I'm talking about?
Yeah, it has to be like a certain quality and things like that. I realized I have this pin on the backwards.
So, yeah.
But yeah, no, I'm the same way. It's like I'll get a really good picture done with an iPhone, and I'm like, oh, why couldn't this be quality? So,
but thank you, Wiley, because Wiley says we look the same. So,
oh, I love that person. They are our favorite viewer.
I'm like, as I feel like all my postpartum age is coming out. So good to see you. I'm so excited to be back. Chris messaged me, was like, do you happen to be free today? And I was like, yeah. And so I was just so happy because I've been missing these. I feel like I was like, oh, once a month, I'm still going to feel so connected. And I have felt so disconnected from you.
I know. No, I was so happy because I forgot that nobody was slated because we wanted Jenny, and we kind of kept both dates open because we really wanted Jenny for a lot of reasons. I mean, she's doing such good work with DEI, with perinatal, international work. It's also AAPI month. So, she's a beautiful representation of that. So then I realized I didn't have someone, and I'm like, oh, maybe Liz can do it. And so
y'all had Jenny last week.
Yeah.
Yes. So
it was amazing. I got a lot of good feedback from that live stream, and I always just think like you, Jenny, like all these people that are really just pioneers in our field, it's always like a good reset and reminder of like what it really takes to get better. And I think sometimes we overthink what we should be doing, but sometimes it's just get back to the basics, really work the program, really see value in the work. And that's how I felt Jenny was really just a good reiteration of that last week. So it was awesome to have her on. But now it's awesome to have you on.
Yeah, I'm excited to be here. Let's dive in because I feel like I have a lot of thoughts that I want. Y'all know I always do. So everybody's like, great, Liz has thoughts. That's not abnormal. So thank y'all for joining. We love having you guys. It is almost June, which is crazy. So just a reminder that the IOCDF conference is in less than 2 months. It's about a month and a half out in Chicago this year, July 10th. So if you have not already made arrangements, please make sure you think about coming. If you're there, say hi to Chris and I. We love to see you guys. Chris and I talk about that being like such a highlight for us when people get to say hi and meet us in real life. Chris and I will try to spend a lot of time together because we always get feedback where people will be like, hey, Chris, where's Liz? Hey, Liz, where's Chris? And we're like, well, we're not actually married, even though it feels like we often are because we do this together. But no, we really do. We love seeing you guys. And it's so fun to see your questions and comments and feel like we've gotten to know some of you guys, but then see you in person and get to say hi. So the conference is such an incredible place for Chris and I, and it's something that we both feel like we've grown professionally, we've grown clinically. It continues to serve us to this day in ways that we both understand effective treatment, effective research, and engage with our patients. And it also was a place where we really built an OCD community and we're able to connect and we're able to become the people that we are. So I just want to hear your thoughts, Chris, on the conference and why it's so important to you.
Yeah, I mean, the conference is like no other. I understand that there's a lot of loops for people to get there in person. So always remember we have the hybrid option, but if you can make it in person, I mean, there's a lot of different reasons why the, in-person meeting or hybrid meeting is so important each summer. It's a place, I think, for us clinicians, right, to hear what are our colleagues doing. We get CE, continuing education credit. So sometimes people are bringing kind of like new or fresh perspectives to the treatment. There's pre-trainings for clinicians. So if you want to get trained, I believe this year you can get trained in CBIT, which is specifically for tics. And then I think there's one other training I can't remember the other training, but there's trainings for clinicians, new clinicians, students, associates, all that can go and get really trained. But also for people with OCD and loved ones who are supporting someone with OCD, it's a chance to really connect with other people that are going through it, seeing messages of hope. What are other people doing to get better? Feel sense of community. We have keynote speakers, we have diverse speakers, international speakers. There's a BDD track, which is 2 days this year because we got so many great submissions. So there's things for related disorders. And then lastly, I mean, I always have to shout out, since Liz is on here, I mean, I always think back, the first conference my mom and I ever went to, I forgot that she went to a conference a year before me, but I was too severe to go. But then when I went to the conference, it was in San Diego in like 2010, I think it was, when we were looking back. Somebody put it in the chat last time, but I was able to see Liz speak. She was speaking, and she also, I think you did a talk with your family that year as well. And it was just an opportunity for me to see somebody who was like young and going through it and doing better and doing well. And I think before seeing you speak, I had this idea that it was like kind of maintenance, right? Like maybe somebody who, gets a spinal injury and is never going to walk again. Like that's kind of how I felt OCD was. It's like, this is sort of your life and you learn how to just manage the symptoms. But I remember seeing you speak and thinking, okay, maybe I can get better. And I remember even my therapist said, unfortunately, I had to leave the conference early. I got really triggered and it was too hard to stay. But I remember my therapist the week after, she was like, wow, you seem like you have this renewed energy. So just hearing, Liz speak and talk about her success was such a bolster for me. And I think that's another kind of magical experience, is seeing people who have gone through this journey, gotten better. And it lets you know that you don't only get better by managing symptoms, you can really thrive and have 4 under 4. My God, Liz, 4
yes.
little ones.
Well, thank you. And the same to you, right? I think for me, the conference was a place where I got to meet other individuals with OCD, and you and lots of others really joined advocacy at the early stages before a lot of other people were doing that. And we got to start to advocate together and share our story and grow and learn from each other. Like I have learned so much from you and your treatment, and we all do that, right? We learn and we grow. And I think I would swear you guys would think I called Chris before the live stream today. I promise I did not, but literally I was going to tell you, I wanted us to talk about language and outcomes, because I had a session this morning where we talked a lot about that. And we were talking, she was saying do you feel like after treatment, OCD becomes a distant memory, or do you feel like it's something you always have to manage and you always have to be doing ERP? And I was like, this is my soapbox right now, is how we have to talk about language, and we have to talk about, are you using ERP to be able to function, or ERP to get to freedom? And I promise I did not call Chris and say this, right? But that's exactly what I want us to talk about today, is do we believe and are we living as though the best we're going to get is struggling with our illness forever, but getting to where we can be functional and struggling? Or do we understand that there actually is hope, that we can truly get better? We can truly live the life we want to live. And I just think that is so, so critical. And I really believe, and we need to do some disclaimers and then hop in, but I do believe that it's so important for us to talk about that today, is what language are you using? And is the language that you're using potentially keeping you stuck in a certain mind frame and stopping you from doing treatment all the way, doing that final piece, really addressing all your core fears, and kind of keeping you stagnant or stuck in treatment? Or is it truly getting you free from your illness and getting you to a place where you can trust yourself and you're not, if you're still, I'm going to pause because we will dive in a second, but that's our snippet. But I'm excited to dive in. The conference is amazing. I think both Chris and I know everybody that we encourage to go. While for many people, just like Chris talked about, there are some exposures inherently in being there, but there's amazing support built in. And it's a great way for you, your family members, or you, if you're a clinician, to learn, to grow, and to get more immersed in this amazing community. And I believe, sure, it's biased, but I really think it's true, that the OCD community is the best community in mental health.
100%. I mean, absolutely. I agree with that. People are so kind. People are so loving. I want to do a quick shout out. I'm not going to say their name, but if they want to put in the chat who it is, because I see that they're here today. It was the sweetest thing. Somebody that watches our live streams donated to the IOCDF in my mom's name and my name. I think my name, definitely my mom's name, but maybe my name too. But I see them in the chat right now. I'll let them say their name if they'd like to, because I don't know if they wanted it to be anonymous. We found out they donated, but I mean, just how cool is that? They get a lot from the family group that they attend. They love our live streams, and for them to just say like, hey, we love what the IOCDF is doing. This person I haven't even met in person, right? It's why I give so much of my time to this community, is because it's such a great group of people. Like, I leave the conference, I hate the end of the conference. Like, conference blues is real. It's like,
although we are tired, it is nice to get some sleep.
But I'm like flying home and I'm like, no, why isn't it one more week? But I do love this community. And I think just seeing on the chat, right, in the live stream every week, it's so nice, because obviously we try to get to as many questions. Trust me, Liz and I have so much anxiety not getting to everybody's questions, but sometimes I'm okay because I look and it's like other people jumped in and answered and offered support. And I think it's a cool thing to just have community, because we're all going through this together. There was a client that I had yesterday who had a eating disorder, and now she's getting treatment for OCD. And she was like, Chris, OCD is hell. Like, before it hit me, I didn't even know what it was. And she's like, I don't want my eating disorder back, but if I had to pick one or the other, she's like, people always think the eating disorder was harder. She's like, people don't know what it's like to have a brain that doesn't turn off and is always trying to show you the worst things that can happen in life. And she's like, it's like living in a horror movie. So I think that's why we do the work that we do, is just so that people can get relief, because it is really hard to have your brain attacked. So this community is incredible.
Yeah, it's the best. So yeah, I couldn't agree more. So jumping in live stream today. So just a couple quick reminders, and then we get to talk all our favorite things, and of course, answer your questions. So first and foremost, please put questions, content you want us to address in the pane on the right-hand side of your right-hand side. Yes, right-hand side of your screen, my left, your right. And we will be sure to get to those today during the live stream. Of course, anything we don't get to, we do put in a document that we try to slowly get to those answers as well. You can always go to the YouTube page, go to IOCDF, and be able to see all the past live streams, lots of different content. We'll refer to it a lot, actually. We'll say, oh, we think you should watch our BDD live stream we did, or the OCD 101 with the Bramowitz, or whoever it might be, because there's a lot of great content there to always check out, and you can watch these later. However, it's important to remember these live streams are intended to be educational and not treatment. They should not replace treatment or be used for your own therapeutic interventions. Instead, they're meant to be education and support. We love having y'all here. We love being here, and we are so grateful that IOCDF offers this amazing educational resource. You can go to iocdf.org to learn more. You can learn more about upcoming live streams, put content you want to see, and of course, go to the Find Help section if you want to find a provider near you. So let's hop in and start with language, because this is my soapbox. I get so upset and anxious, yet also like, what's going on? So I just want to give a little history. So when I first received intensive treatment, it was in 2005, right? So about 20 years ago. And when I was first receiving intensive treatment, there really was this, I don't want to say just belief, but like knowledge and education that the goal of treatment was to allow you to function and to be able to manage your symptoms. And it's what was said. It's what was in books. It's what you understood. Your providers would talk about how you are always going to have OCD. It is a chronic debilitating illness, but with effective treatment, you can learn to manage your symptoms. And this language carried over for decades. It is still carrying over now. Actually, Chris and I, a couple of weeks ago, were editing a document where we were like, please update this language. We do not want to say that anymore, right? Because if we send the message that this is a chronic debilitating disease, that with treatment, you can learn to manage your illness, what is the takeaway? Like, what do people think of, Chris? And what do we hear all the time because of this message?
I think the biggest thing I hear is like, why get treatment? Like, if this is going to be chronic, if I'm only going to learn how to manage it, I'm going to have it forever. Like, what's the point? And then I think when you try to then come on the back end and say, hey, but you can get better, you know, it's almost like somebody who says, oh, I'm going to go from having horrible debilitating migraines every day to like slightly debilitating migraines. Like, people don't see a lot of hope in that. And I think that's why that message can be off-putting for people to get help and treatment.
And it sends the message that ERP is something you have to do forever, right? ERP, like I think Chris and I are on this secondary mission. So my first mission is change the language around what recovery from OCD means, but also we are on a subsequent, just as large, if not bigger mission to change the language around ERP, because we feel like ERP has gotten this like bad rap and people think of it as this like cruel intervention that you have to do forever and that it's like just brutal and it's always brutal and I'm always going to have to do ERP and I'm always going to have to use my tools and skills every day to be able to function. Of course, that sounds exhausting. Of course, nobody listening would be like, sign me up. That's what I want to do. Like, no, that is ridiculous. Like, nobody would want that. Instead, I want us to really think about like, what is our goals? What do we want? And the answer is that we want you to get to freedom. We want you to truly get to a place where you don't necessarily meet criteria to carry an OCD diagnosis anymore, to where you have no fear of thoughts, triggers that are going to get thrown your way, to where you truly have freedom from this illness, not you're using ERP to function. What's confusing though, and what I want to break down for a second, Chris, is you can actually use ERP for both. So you can use ERP to get you functional, or you can use ERP to get to freedom. And most people use ERP to get functional. And there's two reasons why. Number one, they don't know how to not use it to just get functional, right? That's all they know. Number two, that's all a lot of providers know. I would venture to say that a lot of really well-trained ERP providers would say the goal of ERP is to get you to function and you need to use it every day for the rest of your life. And they're not talking about ERP as this way that like, if you truly do it, if you do it all the way and you truly lean in and you don't hold on and you're not holding back and you're not white knuckling, what we will find is that you actually will like not have to use ERP anymore because it clicks. Like you truly get freedom. There's like a shift fundamentally in the way you approach OCD and anxiety versus it having to be this approach with ERP. It's like, I don't have to approach it anymore because it actually doesn't even trigger me. So I would love, Chris, for us to break it down a little bit more and talk about like some examples maybe in our own life or with clients where we've seen ERP be used to function. And let's start there.
Yeah, I think a big part of that, and we had a really good talk in the past. So speaking of past live streams with Michelle Massey, I think one of the things that I talked about at my group last night was the difference between really like chasing these kind of surface level obsessions and compulsions versus knowing your core fear, how OCD operates, why you're doing the treatment. Sometimes I'll ask people in my group don't only see me. They some people don't have a therapist or they're from other clinicians. And I'll say like, why are you doing ERP? Like, why are you doing this treatment? And they don't even know. They're like, well, it's just to kind of like minimize my anxiety around a thing. And it's like, no, what you're really trying to teach yourself is like, what in front of me is not a danger and I am able to handle tough things. And so I think what an example of, just learning how to function is sort of like being on the defense. So you get up, you're kind of walking around, hoping nothing triggers you, something triggers you. Let's say, you turn off your hair curl, your curling iron. I should know what it's called.
Hair curler.
Yeah, your curler, right? Like you turn it off and then you walk away and then you're like, oh my God, okay, did I leave it on? All right, well, I'm not supposed to check. Well, I've been checking 5 times, so I'll only check once. Okay, I only checked once, that's fine, and walk out the door. And it's like, you're constantly sort of in this like scared using our ERP just to kind of weasel your way through the day. And that's not what we really want, because you're really just kind of learning how to use it just to sort of get by versus really like diving in and making it a lifestyle.
Yes. So 100%. And I think one of the ways I see it the most, so here's a quick little thing for everybody to think about. When you go to therapy weekly, every other week, whenever it is, do you feel like you're always putting out a new fire or a new trigger or a new crisis? So do you find that every time you go to therapy, it's like, okay, I had this new trigger, I need to talk about it and I need to figure out what to do and I need to set a game plan. And are you constantly having to like game plan or problem solve how to use ERP to approach current triggers in your life? So are you still having triggers that like throw you off? Do you find that that's still happening frequently? Are you still having to respond to those? In that case, you are using ERP to function, right? What that means is that we are still getting triggered. We are still getting triggered frequently. And when we do, we need to have a game plan to approach those triggers with ERP. People ask me here all the time, right? We run one of the residential programs for OCDI Texas in the country. And people will ask me all the time, okay, well, when I leave, what does it look like to do ERP every day? And like, how do I need to plan that? Do I need to have set time? Do I need to have a schedule? And my answer is always, if you find you are getting triggered by certain things repetitively, right? So like you're continuing to find yourself checking appliances or doing something a little bit more frequently. Yes, you need to set some specific ERP, like you need to do some specific exposure, specific ERP to knock that out. But ERP altogether should actually just look like you living your life. It shouldn't be that we have to keep planning and doing, and we need to leave and be like, okay, we know we need to do ERP for this and ERP for that. And like, if we're doing that, then we're just, again, still struggling and using it to function versus I'm living my life and I know triggers might show up and I know anxiety might be there. And guess what? I don't care because I know how to approach those in the moment, right? It's really that, like, it's become an innate response of, are we empowering anxiety or not, versus it has to be planned. Because if it has to be planned, that tells us there's still work we have not done, right? And so number one, if you are continuing to go to therapy and every time you show up in therapy, there's a new trigger and a new thing you're having to make a plan for, we're kind of using ERP to function. Number two, I would love for us to talk for a second, Chris, about white knuckling and the concept of white knuckling. And I think that every single person with OCD can understand it. We can relate to it because guess what? We've all done it, right? We've all been triggered and either not had capacity to address that trigger, or we've like put it on the back burner of something we're going to address later. And we've had to survive through a moment when we're experiencing a big trigger. And the concept of white knuckling is exactly what it sounds like. It's that concept of like, when you squeeze your knuckles really hard, they get white. And it's kind of like, I'm just surviving through this, right? But maybe at the end, you're trying to just either survive through it, or at the end, you're going to do a ritual, in which case white knuckling is still not reinforcing that you can manage anxiety and you can tolerate it. It's like, I'm like panicked having to make it through it. And that is sending your brain all the wrong messages.
Yeah, you know what? I was watching Michael when we had Michael Wheaton on for inhibitory learning. I like rewatched that live stream because I was talking to a client about it. I'm like, why did it inspire me so much? And watching it back, I was like, oh, because I think when we were originally taught ERP, it was all about like habituation, which can still occur. But what the main emphasis now is on learning, right? Like learning things. And so I think the hard thing when you're white knuckling is that you're not learning because you're sending two different messages. So let's say you decide to make that bold decision and say, okay, I haven't eaten in a restaurant in a long time because I'm afraid, I can't go in the kitchen and watch them prepare my food. So I'm going to go to a restaurant and eat. Great. We want that, right? Get back into your life, find your favorite restaurant, order your favorite food. But if while you're eating, you're like staring at the food, you're sniffing it, you're eating slowly, you're looking at your watch, when is this done? I don't like this. And then you leave the restaurant early. Now your brain is getting mixed signals. Is it fun and safe to go to a restaurant, or is it really like a labored activity that you should probably not do often? And so that mixed signaling is why people don't get better as quickly, is because the brain is trying to tug a war and figure something out. So the way that we, don't white knuckle, I think first of all is have that collaborative with your clinician of what you can handle in this moment. Alec Pollard always talks about the small E, the bigger RP. So if going to a restaurant and eating is too hard, but going to Subway where you can watch them make your food is a little bit easier, maybe you start there, but then you have to make sure you're not white knuckling. You're leaning into that sandwich. Well, I hate Subway, so maybe I should use Jersey Mike's. Jersey Mike's is amazing. Like
Jimmy John's. I love
Jimmy John's.
I love
too.
Their bread.
Yes, Jimmy John's is amazing. So it's like, you go to Jimmy John's, you watch them make the sandwich, you're eating, you're licking your fingers, you're having a great time. It's like your brain is going to remember that experience and say, oh, I guess Jimmy John's is actually a pleasurable, passion, values-based decision in Chris's life. Let's go there again. And then you're not fighting treatment anymore. You're actually looking forward to it. And now suddenly it's like Jimmy John's is just part of your repertoire. You do it weekly, like myself. That's why I'm broke. And then you just enjoy yourself versus, oh, I have to go back to that place and do that thing I hate. That's what we're trying to get you to see.
And I'll give another example. So here at the clinic 10, 20 years ago, when we've been around for a long time, since like the 90s, early or 2000, I guess, maybe, I don't know. But anyway, well over, 25 years. And when our program first started back in the day, we have 2 blocks of ERP a day. So 2 hours in the morning, 2 hours in the afternoon. So patients go to group at 9 to 10, then they have an ERP block for 2 hours, then group from 1 to 2, and then a 2-hour ERP block. And during that morning ERP block and evening, we always have a check-in and check-out. And 10, 20 years ago at check-in, we would ask patients, what are you going to work on? What exposures are you going to do? How are you going to do response prevention? Do you need support? And what are your starting SUDS? SUDS stands for Subjective Units of Distress Scale. And this is often a way that people in the anxiety field measure your anxiety level, right? So we use 0 to 10. Some people use 0 to 100. I think that's too big. But for 0 to 10, we want you to say, okay, I'm going to go touch that granola and drink this and do these contamination exposures, and my starting SUDS are a 10. And patients in the past, we would do these exposures and we would have you literally sit and habituate and wait until you got at least a 50% reduction in SUDS. So we wanted your SUDS to drop to a 5 before you went and did the next exposure. And so you would literally be like sitting there, just like sitting, touching it, thinking about it, waiting, being triggered, being with it, until your anxiety reduced. And then at checkout, it would say, okay, what exposures did you do? Did you do full response prevention? Did you do any rituals? And what are your ending SUDS? And maybe you'd say a 5. And we would literally write it on the board. And it would be like, what was someone's starting and ending? And everybody could see each other's. And it was this like motivating kind of thing of like anxiety reduces and habituates, but also like you do exposures and you sit and wait. There are still some programs that do that. And I want to say before I jump into like what we do now instead, that still like habituation model does work. Like it does have good outcomes. It's not, no one is saying like it doesn't work. That's the model I did when I went to residential treatment and got better and changed my life. However, that is the model I also had when I was just learning to function instead of really getting freedom. And I think a big piece of that was because what were we putting the emphasis on? The emphasis was on anxiety reduction. It was, what are your SUDS? Did they drop? When they drop to 50%, you can move on. Well, what message does that send the brain, right? I'm sitting here telling y'all as a clinician, anxiety is not dangerous. Like anxiety doesn't matter. You can do hard things. But then if the way I'm measuring whether you can move on or not is based on if your anxiety reduced, I'm actually telling you the opposite of that message, right? I'm telling you that anxiety does matter. Anxiety is kind of dangerous. You need to wait for it to reduce before you move on. And that's not what we want to teach people. And so I had someone recently ask me like, oh, for data, can we look at your SUDS pre and post? And I was like, we don't ask SUDS pre and post. And they were like, what? And they were like, well, can you add that back in? And I was like, no, because I'm not going to do that for research because we don't ask that intentionally. So what do we ask? We still ask, what exposures are you going to do? How are you going to do response prevention? Because that's critical. Do you need support? We want to know that. But instead, we ask at checkout, we don't ask SUDS at the beginning. And then at checkout, we don't ask SUDS. We say, what did you learn? Mm-hmm. And we write that down. And guess what? Sometimes what a patient learns is, man, Liz, I learned that like I did rituals. I'm not going to lie to y'all. And these are the rituals I did. And I learned that I feel worse now after ritualizing than if I wouldn't have done them at all. And I wish I wouldn't have ritualized. And guess what? That is still critical knowledge. Like that is great learning. And it's not to beat you up. It's not for you to be like, I failed. That's not what this is about. It's about, did you learn something? I will never forget going through a really tough experience in my life once and personal experience. And I remember someone like asking me a question about it. And I didn't really know this person. I didn't really think it was their place to ask. But I remember they said to me, did you learn anything? And I said, yeah, I did. And they go, then that's all that matters. And I was like, wow, that's a great perspective shift. But it reminds me so much of inhibitory learning and like what we're trying to say, which is it doesn't matter sometimes if you did do a ritual, as long as you learned that actually made things worse. Like that actually promoted my anxiety, made me more stuck in my OCD cycle. That is just as valuable, you know? And so I want us to really be thinking about that. Like when we're doing ERP, are we getting it? Is it clicking? Are we sending messages? And is our provider focused on us learning that like, yeah, you can be triggered and still go do hard things. So for example, when a patient here does an exposure, they don't sit with exposures anymore. They do an exposure and they go do things they want to do. They go make those phone calls. They go manage some work stuff. Like we want you to learn that you don't have to just sit and do exposures and life can't move on because that's not reality. When you are triggered in the real world, I want you to be able to lean in within 2 seconds and move on within 30 seconds, right? I don't want it to be that you have to sit and wait for your anxiety to reduce before you can move on, because the message that's sending is that anxiety should be a like dictator in your life.
Yeah. Or that you can't even function until your anxiety's at net zero. I was thinking while you're talking, like a real life example for everybody watching and what exposures could look like if you're following kind of what Liz and I are saying is my last IOP, there was like a neighborhood grocery that they really liked. And one time when they were there, they saw a worker like make food and then like cash something in and then hand the food. And so the client kind of wrote off that like neighborhood grocery. And the neighborhood grocery, by the way, is amazing because it used to be near my sister's house, and it's actually Greek. So, you know, I already,
of course, who would have guessed, Chris?
I already loved it, right?
Known.
But they have really good food, like healthy food, and he really enjoyed it, but he wasn't willing to go because he witnessed this, and that was like maybe 6 months ago. And so I asked him, I'm like, is this important to you? And he's like, yes, because there's a lot of times where I don't want to go. He lives in a city in SoCal where there's parking's horrible. And he's like, I don't want to have to drive my car someplace, lose parking, go into, you know, a little bit further away. I'd love to just walk to the store, grab some food and bring it home. And so I was like, why don't we challenge that? What would it look like? Like, talk to me what you want it to look like on an everyday basis. He's like, I want to be able to go. I want to grab food. I don't want to scan what every worker is doing. I don't want to assume that some worker is being unsafe or they're sick or whatever. I just want to notice what's in front of me, get my food and go. And same as you, Liz, it's like once we did that, we processed it right after. It's like, what did you learn? Teach me what you got out of that. What did you learn today? What can you tell your wife when she comes home later that you learned? How can you make this learning universal? Because you and I can't go to every store that triggers you. We'd be in treatment for months and you don't need to. Right. What did you learn going to this store, and how can you apply that learning to other stores? What did you get out of this exposure? What was the enjoyment? How is this going to enhance your everyday life? And like you, Liz, it's like, what really works? Like, what did it take to do this today that you could utilize in other exposures? And then what kind of didn't work? Like, what do we have to make sure that we're checking next time? And that's the conversations I have. And I always feel good walking away as a clinician because I'm like, they got it. It's kind of like in school. I'm not just doing the problem. I don't want my clients to just do the problem. I want them to explain to me, how did they get the answer, show their work. And that's what I'll notice, people walking away and they really get it. And then it's always like, I was able to do this and this and this, even though you and I didn't discuss it, because it was kind of the same thing as going to this grocery store.
And my favorite thing is I feel like when patients are able to say like, okay, I did these exposures and like, it wasn't as bad as I thought. And like my anxiety reduced. And also I moved on and I'm like, okay, you're getting it. And now, and like you said, then they're like, and I also went ahead and did this and did that. And you're like, okay. And like I had a patient today and she's only on session like 5 or 6. And she was like, it's clicking. Like, I get it. Like the more I'm facing my anxiety and like addressing it head on, the more I'm getting like relief from it. And I'm building my own confidence and trust in myself. And I understand where like, if I don't do that, it actually does the complete opposite, right? When I do a ritual, even though it's in an attempt to feel better, it makes me question myself more. I don't trust my own like decision making. I get more stuck in the unknown, like all the things.
Yeah, exactly.
So,
that's what we want clients
to get you to freedom.
Yeah, it can get you to freedom. It can get you back to like really learning and understanding things, trusting yourself, being confident. I mean, I think that's the thing I tell family members is by doing these things for them with accommodations, you're taking away that person's ability to like face something that's tough, land on their feet, accomplish it, and then feel accomplished and feel good. We want that sensation. So people start to want that more and keep facing OCD.
100%. And the one thing I will say is, I would encourage you to think about asking your provider, like, okay, with effective ERP, what can I expect? And if your provider is saying things like, well, with effective ERP, you can learn to manage your symptoms, but like you always need to be in ERP, you always need to be doing treatment, you always need to be on top of it, or you're going to, because you might always have triggers, challenge them. It doesn't mean you have to leave them. You could, but you could look for it. But like challenge them by saying things like, actually, like you can say Liz and Chris, but you can be like, I've actually heard that that's pretty outdated language and that we actually can use ERP if it's appropriately to get to our core fears and get to freedom and to do it all the way. And so the questions, 2 things I always ask our patients here is, when you do ERP right now, what are you holding on to? And almost everybody is able to write things down that they know they either haven't told their provider about, or they're kind of holding on to, or they're like, I'll do it this far, but I don't want to go that far, right? But there's always a few things that it's like, I'll do enough to be able to function, but like I can justify why I don't need to do this exposure all the way. But by not doing it all the way, then you know that you're keeping yourself stuck. You're keeping that fear alive, and that trigger there, or something that will continue to be triggering. Second thing, number 2, is can you make it where you do exposures to where they cannot be undone? If you do exposures, but you're still holding on to like, but if I want to, I can choose to ritualize later, or I can choose to do something that's going to make me feel better. We can guarantee we're going to continue to be triggered by that thing, because we're leaving undoing it, ritualizing on the table, right? We're leaving that as an option. We have to take it off the table.
100%. And I want to tell people watching this too, one thing, if you heard Liz say earlier, I think about Allegra and I went to Boston for the IOCDF walk. And, I was thinking about it. There were so many things that happened that would have been an exposure to me many years ago. Like my neck pillow fell on the ground. When I went into the bathroom, like whoever was there before, it was definitely a man, pissed all over the floor in the bathroom at the plane. So I stepped in it because you can't really see in that little bathroom and stuff. My brain, I watched once that you should sit in the back of a plane because it's better to survive an accident or a plane crash. And we were in the front. There were so many different things. We got back to the hotel and I had less time to pack up, and my brain used to want to check for 3 hours, but none of that came up for me. So the thing I always tell people is like, you will get to a point that things that used to be exposures aren't even exposures anymore. Like you just don't care. And I think about it, people ask me all the time, especially in my group, like, do you still struggle today? It's like, today they had construction on the on-ramp and it caused me to be late. I totally forgot to grab a straw for my matcha. And when I drink it without a straw, it makes my teeth sensitive. Those are the kind of things that annoy me on a daily basis, but I didn't wake up in a sense of anxiety, of panic, of obsessions. And it doesn't mean that Liz and I never face anything, but it doesn't feel the same way it used to, because we have this faith in ourselves and the tools. So you will get there. I know it feels so far away, but Liz and I are living proofs that you can get there and you can thrive.
Yeah, ERP should truly feel like it lifts this cloud, it lifts this fog. Actually think about it like a sinus infection, right? When you have a sinus infection, you have this like brain fog, and it just feels like no matter what you're doing, you're not productive at work. You're not productive on the phone with your friends. Like you can't function the same way. You can't think the same way. Everything feels off. OCD is giving you brain fog. Like it is OCD fog, that it's making you question everything, feel more unsure than you've ever felt, no matter how many rituals you do, feel more confused than you should feel. And when you quit giving into OCD, the fog truly does lift, and it allows you to see things at face value. It allows you to trust yourself. It allows you to no longer get stuck in rumination and hours and rituals trying to figure things out and feel better. And instead you just get to live your life. And that's the freedom we're talking about and that we want you fighting for. And so if you are with a provider where you feel like you've been stuck, you've been doing the same things, you're stuck in a rut, push the provider to push you, or consider changing providers. And if you're looking for a provider, look for a provider who really understands the way that you can address ERP and address your core fears, and not just use ERP to address current symptoms, because that is a big difference in getting to freedom versus functioning. We have questions. We need to hop in. So I love this topic though. And y'all know we could talk about it so much. So you guys are so sweet. Love all of your kind comments and reading through that. Gail, I would love if we want to do a conference in South Africa, like just throwing it out there. If IOCDF wants to send the conference, like we wouldn't be upset. So
Liz, while you're looking for a question, speaking of international, we got this comment pre-submitted and it says, "Hello from Greece. So happy to share that the Hellenic OCD Foundation is now a reality. Such a breakthrough for OCD sufferers and their families in Greece. So honored and proud to serve as the first president and lead this amazing group of volunteers who made this come true." And they just followed me on Instagram. So my mom saw it and she's like, "You have to go out there and speak." So I just want to throw that out there.
Feel free to follow me too on Instagram so that Chris and I can message y'all and you can bring us there to speak. Just saying, we wouldn't say no. That's all we're saying. I
love the international, it's like we really are the International OCD Foundation. Jenny talked about the stuff that she's doing in Portugal, and it's just so good to see people all around the globe getting the support that they need. So amazing, amazing, amazing.
I do love though when I get Cygnus calling me.
It was fun.
For a patient to fight for them. Like, this is the other piece of advocacy, guys, is like fighting insurance for coverage for our patients. Whew. Sorry, got a little, that activates me in more than any OCD trigger. It's like, oh, what's that going to be? Okay, so let's keep going. Thank y'all so much. Y'all are so sweet. And yes, so somebody asked a question about inhibitory learning versus habituation, and we actually covered that on our own. So feel free to ask further questions around it if you need to. Love the comment about functioning well despite OCD is great, but you don't have to settle for that. Let's really fight for freedom. This is so, so important and what we all fight for. Yeah, let's start with Nathan's question at 11:18 my time. It's not really a question, but he said, I have depression and OCD, so finding motivation is one of the problems. Chris, you want to talk a little bit about how we can find motivation when depression is coupled with OCD?
Yeah, I always want to remind people that having only OCD is pretty rare. I mean, when we look in the DSM, it talks about 68% of people will have a co-occurring depressive disorder. And often it's because OCD is a very debilitating disorder. Although we're talking about, obviously, treatment can get you out of that. Like when you're first hit, especially prior to a proper diagnosis and evidence-based care, it can be really debilitating and depressing when you start to notice your life fall apart. And always remember there's a medical term with depression. And basically it talks about that everything kind of slows down. We start to feel sluggish. We start to feel deactivated. We often want to like lay in bed under the covers, close the blinds, etc. And it is really important that your provider, your clinician is addressing the depression as well. I would say probably 9 out of 10 times the depression is correlated with OCD. Sometimes you do have to address other things like a family loss, etc. The good thing is we know that one of the best things we can do for people is a combination of addressing the OCD, because often that will help lift the depression, but something known as behavioral activation. We want to get you up. We want to get you out of the house. We want to get you moving around, etc. Now, I know that's easier said than done. It feels like you have 50-pound weights around your ankles, but the idea is to get you into events. Now, one thing I try to do is combine an OCD exposure with that. So I have a client that really is triggered by being in public spaces and wants to go to a conference and is depressed, experiencing depression. So part of her treatment is to go to that concert. It's going to get her back into something she loves, activate her. Also, it's going to be an exposure. Plus, she's connecting with her friends. And so one thing that Dr. Jamie Fusner, who's a great researcher, he's on the scientific advisory board for the IOCDF. When I was seeing him for medication, one of the things he used to tell me is like, Chris, be out of the house every day, 9 to 5. You cannot be in your house. It will feed the depression. So I would say, Nathan, really work on that depression as well. But OCD treatment will help with a lot of that.
100%. Yeah. So, and remember behavioral responses, right? So behavioral interventions work for depression and OCD. So yeah, it's really about doing the opposite of what your depression wants, the opposite of what your OCD and anxiety wants. Just the specifics of it look a little bit different, but your provider should be a CBT provider no matter what, if they're treating OCD, and they should know how to treat depression.
Yes.
Thank you so much, Amy. Amy said that what is the function of the behavior has been such a good question to ask, even outside of OCD. And I love that. So I've talked a lot about that. This is when I'll say things, people say like, well, what is in my questions, like, what is the function? If the function of the behavior we're doing is to reduce anxiety or to try to make us feel better in the moment, it's probably not going to be helpful and it's going to get us more stuck.
Yeah, if I could use a quick example, we were talking about that in the group, and one of the members has ROCD, and his obsession is like, what if I'm not doing enough and my girlfriend gets bored and leaves me? And so he's planning all these things for his girlfriend. And I often let the group jump in and answer instead of me. And they came to that same conclusion. They're like, hey, making plans with your girlfriends is not inherently OCD, but if the whole purpose that you're doing it is because you're so afraid she's going to leave you, that's where the OCD comes in, because that's your general driving force.
And again, that's when we talk all the time about values, right? But like your value of spending time with someone you love and doing something special, if that's your value, we want you doing that. But if you're doing it to appease OCD, now it's actually like not even values based. You're doing it as a check mark because you feel like you have to. It's a ritual versus like you actually want to go to this fun activity or go do this thing, and it takes kind of the fun out of it, right? And it can become, unfortunately, sometimes a self-fulfilling prophecy, right? I feel like I have to plan things because I want them to not get bored, but then they get bored because I'm planning all the time as check marks versus actually planning engaging fun things.
Yeah. And then it just becomes like, and your partner isn't dumb. If they have a basic understanding of OCD, they can see when something's labored and anxious driven versus a genuine want.
100%. One thing I'll say, I've seen a couple things about like, I could manage OCD for the rest of my life if I was more financially secure. Don't ever put caveats or like any sort of reason why you're willing to have OCD forever. I want you guys to really be pushing against doing everything to have freedom. Like, it shouldn't matter if we are financially secure or not, or wherever we're at, we should not settle for having OCD. And remember, if we settle for having OCD, that also means we're settling for struggling, because OCD will continue to increase if we leave it there. A lot of y'all talking about some of the ways that white knuckling, different stuff. I love the comment of like, I still do some exposures that way, and I'm not really doing the full response prevention. It's hard. Yes, it is hard. 100%. It is hard. It is difficult. And that is how you're going to get freedom. But like, doing it a little bit is not going to get you where you need to be. My goodness, there's a lot. Where do I go? Okay. Federico. Dear IOCDF team, in 2025, I'll mark 20 years since I was diagnosed with OCD, and I truly believe that attending the conference this July would be a transformational step. So yeah, they would love to find a way to get to the conference. And Federico, I hope that that can happen. And I do believe IOCDF has some different options for helping support individuals to get to the conference. So definitely go to iocdf.org for more information as well.
Yeah, I think there's scholarships, you could volunteer, and there's always the virtual option. Yeah.
Yes, absolutely. So that's great. And I love that you're doing all this amazing advocacy. Alex, she wrote at 11:31, how do you deal with intrusive thoughts that happen right when you do something or right after? It makes you doubt your intention.
Yeah, one thing I tell clients a lot of times is like, be prepared for that, right? So let's say your OCD we don't even have to necessarily know your subtype, Alex, but let's say you go to do something, right? Let's use harm OCD. So let's say, you go and you hug your niece and you kind of give her a cute little squeeze and then set her down and she walks away, and then you ask yourself right after. So you have this intrusive thought, wait, did I squeeze her too hard? Did I want to hurt her, right? Obviously, we know, having, being clinicians, that that's OCD. It's a doubting disorder. It's going to doubt your intentions. You picked her up, hugged her without thinking, because that's her true self, right? And then the OCD is like, why did you squeeze? Why did you squeeze? What I always remind people is the idea is that just because you have an intrusive thought, just because you have a doubt, does not mean it deserves your attention. Just because you're aware of a thought does not mean it's dangerous. And so what I tell clients is that's really what response prevention is. If you do something, let's say it's deliberate, right, an exposure, and afterwards there's this doubt after, the mental compulsion is trying to discover your intention. And I can promise you, when you're triggered and you're in that anxiety that we're in, that moment is the worst time to do compulsions to try to get clarity, because when you're trying to do those mental compulsions to figure out why you did something, you're going to doubt it even more. It's like making a copy of a copy of a copy. Pretty soon you're so blurred that whatever OCD tells you, you just take as fact. And you're like, wow, I'm a horrible aunt. I squeezed my niece on purpose because I wanted to hurt her. And then you're going to walk away with that belief about yourself. So what I tell clients is, don't let OCD's monologue become a dialogue. Great. It wants to share its opinion after you hug your niece. You don't have to respond.
I love that. I love don't let the monologue become a dialogue. Yeah. That's going to be my new.
I tell my clients, how many times do you ignore a text message from somebody you hate? Ignore OCD. No, don't ignore OCD. But what I basically mean is, like, you shouldn't be spending an hour, 2 hours, 3 hours in your head trying to go back and forth to discover your intention, because you will not get it in that manner. Nobody ever comes to a beautiful conclusion from rumination, from mental compulsions.
100%. Next question at 11:38 from Spence. ERP is working pretty well for me. I can see freedom versus functioning as a quantitative difference in terms of level of anxiety, but I can't quite grasp the concept, as there's always anxiety. So what I will say to this, Spence, is maybe not, is that actually what we know is that when we truly address it at the core and we're not responding, the anxiety will decrease. So you should actually have a lot less anxiety, a lot less triggers, and they won't have as much intensity or any at all if you've addressed them all the way. So if you're just constantly addressing triggers when they come up, ERP for every trigger, yeah, they're going to keep showing up. They're going to keep having anxiety. It's going to feel like this game of whack-a-mole. I do one, another one pops up. Versus if we also address the core fears and we get to a place where we're truly allowing distress and anxiety to show up and not responding to it at all, right? Responding to our life, our values, and not holding back, you will see anxiety go down, and there doesn't always have to be anxiety. That does not mean anybody in this world will ever get to a place where they'll never have any anxiety at all in their life, right? That's very different. But we all know the difference between clinical anxiety and distress that OCD and anxiety can bring on versus normal anxiety that everybody gets for different things in their life. Next at 11:38, Junebug. Junebug talked about how one of her grandkids does some behaviors of like licking their lips and it gets chapped and using Vaseline. She wants them to get counseling and it might be autism, or OCD. The answer to that is like, we actually don't know, right? This could just be a habit that a kid does and like their lips get red and they need chapstick or some sort of Vaseline. And it could be something to not really worry about at all. Or it could be something that is one of many other symptoms that is clinical and needs to be evaluated and addressed. So there's no way to say that's definitely OCD or that's definitely a specific behavior. But I would want to know, like, what ways does it impact life functioning? What are other behaviors going on? And then get a good assessment by a clinician who can help understand where it's coming from and what it's rooted in. This is just a quick reminder for all of us that just because we have repetitive behaviors or even intrusive thoughts or obsessions doesn't always mean it's OCD.
Yeah, assessment. It's so important to see someone that understands OCD and related disorders so that you can get the correct help.
I love Amy at 11:41 said, good news, 2 therapists I know who were considering using EMDR for OCD will no longer be doing that because they talked and they're going to be at the conference this year to learn. So I love that. This is what this is all about, is like, can we teach clinicians and individuals to advocate for effective evidence-based treatment and help individuals get that training that they need? And there's so many ways people can get evidence-based training. So I love that they're going to come to the conference and really learn and get immersed in OCD because that's what it's all about. Love all of y'all's questions. I feel like there's some really good stuff here. Y'all are chatting with each other. So many great feedback and, shout outs about IOCDF. So of course we love that so much.
I see a question while you're looking at 1231 from Twitch. It says, I'm making a lot of progress using CBT and ERP with my therapist to treat my contamination and OCD, but I'm still having a hard time reducing my compulsions in the shower so I can take a shorter shower. I think there's a lot of ways that you can navigate that. I always ask clients first and foremost, do you understand why your shower's longer? What kind of rules have you created? I think what's tough to always remember about like a shower, for instance, wiping, is it's not something that's very communal. So we don't always know, like, I know for me, like washing my hair, I didn't realize you weren't supposed to use half a bottle of soap because my OCD had taught me to do it that way, but I wasn't watching many people wash their hair. So I think starting there, right? Like, do you recognize while you're doing these things? Do you understand how they're compulsive, et cetera? And do you recognize why they aren't working and why you want to get them reduced? So having an understanding. But what I would work on is you can create your own kind of like list of compulsions that you're doing in the shower and then decide what you want to tackle first. So a big one I see for a lot of people is washing their hands in between every single body part. Maybe you start there. I don't think people recognize how much time that adds to have to wash your hands, in an OCD manner, because it's usually elongated in between every single thing you do in the shower. So maybe you start there, or maybe you're washing your hair 3 times, so you reduce it to 2. So really talk to your clinician about and understanding why, you're doing what you're doing, and then creating a very strategic plan so that every shower, the cool thing about getting better with ERP is a shower is probably daily. So this is something you can practice daily, and you're just working on getting to the shower that you ideally want. What steps do you have to take to get there?
100%. Yeah. And it will get better. What I always will say, one more little caveat to think about, is sometimes ripping the Band-Aid off is much easier than like slowly lifting the Band-Aid like my toddlers want to do. And I find it to be a nightmare. So I just tell them to look away and rip it off. Remember that with this too. Sometimes, like when we have a lot of rituals, like slowly reducing one at a time can actually feel more brutal and make the shower more exhausting and daunting than like, I'm just going to actually do a lot, get rid of a lot at once, or at least get rid of a big chunk to where it's going to feel freeing. And I know that if I got rid of that one ritualistic section with my lower body or my hair, whatever it is, like if I really kind of knock out more than a little bit at once, that's also when that momentum will start to build, versus if there's like 100 steps and we knock out one and we still have 99 to go, it feels exhausting. So just think about that too. Sometimes it is better to do it in bigger chunks and to kind of rip that Band-Aid off than to do a little bit at a time.
Yeah, my showers were like an hour, and going to 50 minutes was just too hard because it was even more difficult. So literally just like jumping in with an aim of 20 minutes and cutting out 40 ended up being easier.
Next question at 11:51, and this is a great question we talk about all the time, and we'll end with this and then some final takeaways is, my OCD has taken a backseat as I pursued treatment for codependency and other issues. How do you balance ERP when other issues take priority?
Yeah, it's very challenging. I mean, obviously, in an ideal world, everything that you're going through, one provider can be an expert in. But what I would say is, like, Liz and I eat, breathe, and sleep OCD and related disorders. There's a lot of conferences, we speak at them, but we also attend them. We also attend trainings. And so it is pretty difficult to find someone that is going to be really, specialized in many different things. But we also know that, sometimes something is a lot louder. If somebody's going through PTSD, it may be taking up the majority of their attention, and they need to address that first. But in your question, let's say you are pursuing treatment for something else. You would want to, if you can, also see a provider who specializes in OCD. And one of the things that Liz and I talked about today is ERP doesn't necessarily need to rule your life. You can look at opportunities to initiate ERP in everyday things. So I have clients sometimes have ERP obsessions around eating. Well, they got to eat. So let's make ERP around eating, since they're going to do it anyways. Or let's say when walking their dog, where they're going to walk their dog anyways. So try to instill the ERP if you're finding that a lot of your time is taken up kind of addressing these other disorders, trying to find ways to incorporate ERP in other areas. And if you can work with a team that can be collaborative, that's great. If you could find someone that treats all of that, that's great. The only time I tell people, hey, let's maybe pause ERP, is some clients, especially with a personality disorder, have really difficulty with emotional regulation. And that is kind of taking over their life. And they may need some DBT skills and some other skills first to be ready to do ERP. So we would work more on ERP readiness versus jumping in right away. But I have a lot of clients that might see somebody for trauma or PTSD, but are collaborating with me for ERP. And if they feel exhausted from all this treatment, I try to find ways to incorporate their treatment and things that they're doing every day as it is.
100%. And we've talked about this before, but sometimes when you also think you're ready to do ERP, your provider might say, actually, we want you to address this first. And that's really important, so you want to be working with your provider on, like, when do I reincorporate OCD treatment? What does it look like? What do I need to address first? Because sometimes there is a stepwise pattern. Safety always comes first, right? So substance use, suicidality, emotion regulation, like things that could create safety concerns, those have to happen before we can do active ERP. If someone has a comorbid trauma diagnosis and has PTSD, we want to be able to tease apart what is trauma response safety behaviors versus OCD rituals. So again, this should be collaborative, and your provider can help guide too, of like, how do we balance this? What does this look like? And like Chris said, sometimes you're working with two providers. Sometimes your ERP provider is then making sure you incorporate continuing to do the old work you've started as well.
Absolutely.
Okay, 12:02. We went over. We could go for another 2 hours. So I love being here. Chris, any takeaways from today?
Yeah, a couple of final thoughts. I mean, somebody said in the comment that their provider still does SUDS. What Liz and I always try to remind you is that we did a lot of traditional ERP in our own care, and we still got really great, but everything evolves. And if you find SUDS helpful, some clients that have come and seen me worked with previous providers that use SUDS and they find it very helpful, that's okay. All I do is add some education and say we've gotten to a point in the research that you can still function with anxiety. Bless you. So if you have your SUDS only go from a 10 to a 7 in an exposure, it does not mean that you've failed. It just simply means that you're learning a lot and the anxiety may take a little bit longer to go down. However, you can still thrive. There was a really good podcast that John Abramowitz did, and he said the point of ERP is to have anxiety, yet still navigate life and function through it, to teach yourself that anxiety should not be the decision maker of what you do that day. So remember that. Federico on LinkedIn said, how do they find a treatment program? There's great programs that Liz runs and programs across the globe. So don't forget to go to iocdf.org/find-help to find a provider near you. And the last thing I'll say is, don't forget, if you experience body dysmorphic disorder, or a loved one does, or you're a clinician who's interested in learning more, this Saturday from 11 a.m. to 6 p.m. Eastern time is the second annual online BDD conference. We are collaborating with the BDD Foundation in the UK, so we're going to have a lot of international speakers. So we'll be there this weekend. So if you go to iocdf.org and look under conferences, we hope you can make it. And lastly, I'm going to be excited to see Liz in person and all of you who can make it this year in Chicago.
100%. My biggest takeaway is to also think about the function of the behavior, the function of your responses across the board, whatever that might be. When we talk about that, like SUDS, if functionally like SUDS works for you, great. If SUDS is actually continuing to make you focus on anxiety, then it isn't helpful, right? So that's a way to kind of think about that. And you can talk to your provider about that and say, hey, this is like, you can say like, I listened to this live stream, you might want to listen to it. Feel free to send them the link. But like one of the things with SUDS is that I find it still puts the focus on anxiety. And I really want to change that narrative, both internally and externally. And I feel like thinking about things less in like, what are my SUDS? Now, I will tell you, I still ask outpatients sometimes, how high did your anxiety get when you did that? Because I still sometimes want to gauge, like, how hard was that? What did that look like? How did you work through it? What are the levels you're at when you do give into rituals? And like, how do we increase and build that distress tolerance skill? So I might still ask it sometimes. It's just like, is SUDS a huge part of the way we do every single exposure? And do I feel like that's putting the emphasis on anxiety? And if so, talk to your provider about it. You should be able to talk to your provider about questions, about things you want to do different. You should never be afraid to do that. So that's my biggest takeaway. I love being here. I missed you guys. It's so fun. And Chris and I will be back next week. Next week, we'll be joined by Dr. Saxena, and Sanj is on the Scientific Advisory Board and also the clinical director for the International OCD Foundation. We're going to be talking all about new treatment recommendations and IOCDF's kind of stance, but also ways that you can find and navigate that through IOCDF in the way that they get to conclusions about how they say something is evidence-based, how they push and promote what you should do first and what you should be understanding when you're thinking and talking about treatment. So be sure to join and come with any questions so that we can answer those live next week, same time. So Wednesday at noon Eastern time. We'll see you there.
Take care, everyone. And thank you for your kind words. We enjoy you. Bye.